The province presented new modelling data yesterday, and the co-chair of Ontario's COVID-19 Science Advisory Table said, in the days ahead, doctors will have to make choices they don't want to make. Choices about who will get the care they need and who will not. What will guide doctors in those excruciating moments are triage protocols, which Ontario updated in December. With us now to consider the parameters for making such life and death decisions, particularly as they may apply to people with disabilities, we'll introduce our guests, as is our custom here, from furthest away to closest to our studio, starting in the nation's capital with Dr. James Downer. He is the head of the University of Ottawa's Division of Palliative Care and a critical care physician at the Ottawa Hospital, who co-led the drafting of Ontario's crisis triage guidelines. In Kingston, Ontario, Udo Schucklenk, Ontario Research Chair in Bioethics and Professor of Philosophy at Queen's University. In the provincial capital in Parkdale, Mariam Shenouda, staff lawyer at the Arch Disability Law Centre. And in Midtown, David Lepofsky, chair of the Accessibility for Ontarians with Disabilities Act Alliance and a visiting professor at the Osgoode Hall Law School. And we're delighted to welcome all four of you back for an important conversation on TVO tonight. Just before we get to it, we thought it might be useful to have a short explainer on what crisis triage actually is. So Sheldon, why don't we start with that, if you would?
What is crisis triage? A crisis triage protocol is activated in the case of a public health emergency, such as a pandemic or natural disaster, when the demand for medical services dramatically exceeds the supply. A triage protocol is a set of guidelines to determine the allocation of limited medical resources during such an emergency. The principle of triage is to save as many lives as possible by prioritizing emergency treatment according to criteria often including the person's chance of survival or life expectancy. For example, under a triage protocol, it could be considered justifiable to remove an older, frailer patient from a ventilator in order to save a younger patient. When the priority of patients can't be made based on medical need, some triage protocols determine treatment by first come, first served, or lottery system.
Okay, thanks to Jan Jagannathan for that backgrounder. James Downer, let's start with you. How close, in your view, are we in the province of Ontario today to having to enact crisis triage protocols?
Well, we haven't enacted them yet, but I think it's fair to say that we are getting close. As of this morning, we had about 404 patients with COVID in our ICUs, but our total ICU census for the province is at a little over 1,800 right now. For comparison, a year ago, we didn't have, on any given day, I think even 1,700 beds available, and now we're caring for 1,800 patients. So we've definitely had to expand our capacity, and we're starting to feel the strain, particularly in some areas around the GTA and in the southwest of the province. It's important to note that the limitations are really probably not beds anymore or ventilators, but actually trained staff. You can buy ventilators, you can buy beds, and you can find space in a hospital. It's a lot harder to get trained and expert staff to manage critically ill patients in a short period of time. And I think that's more than likely going to be the limitation we hit, because of course, many of our staff are starting to feel the strain themselves, the effects of the COVID pandemic through illness, burnout, or other problems, family considerations, that we're feeling a strain on our human resource capacity.
Okay, let me jump in with a quick.
Say we're not there yet, but we're not far.
Gotcha. Let me do a couple quick follow-ups with you, because people may be doing the math in their head right now saying, okay, 400 patients right now, capacity for 2,100 in ICU, that feels like a big gap, so why would we be close?
Well, 2,100 would be the actual physical ventilators and bed spaces. And as I just mentioned, actually the limitation is probably not going to be ventilators and bed spaces, but rather staff. Plus the fact that we may have a big surge in one area of the province and not another. We're doing our very best to move patients around as quickly as we can, but that's not as fast a process as you might think. And the modeling data from that we all saw yesterday suggested that in a matter of weeks, we could be looking at 800 to 1,000 COVID cases, which, when you already are dealing with 1,200 to 1,400 cases of people being critically ill for other reasons, nothing to do with COVID, and that's not likely to go down substantially. The math is not complicated. We will just simply not have enough space for everybody.
Okay, some of you were on this program several months ago when we first tackled this topic, and James Downer, one more fast follow-up with you. The original triage protocols came out in March. They were rescinded in September. And you, as we suggested off the top, you're part of the sort of table of experts who tried to draft those protocols. How come they were withdrawn in September?
Well, so they were withdrawn with the idea that they were being replaced with a newer and sort of more updated guidance. The process is a sort of a process of continuous revision and improvement as we get more data and as we get more input. So, when wave one happened, it's important to remember that we saw all around the world, every other jurisdiction that was getting hit with COVID was being overwhelmed and going into triage scenarios. We had a very, very short period of time to get something ready to go. We got something out the door that was ready for use. Very fortunately, the flattening of the curve did occur. Our public health measures were effective, and we didn't have to use them. But the process was from the start. We refer to these as green documents, right? So they're always sort of constantly in growth and modification as we get more input, more helpful input, and more up-to-date data. And even if we were to have to use triage now, in the coming weeks and months, that document itself would not be considered, I think, final, or that approach wouldn't be the final approach. We would always be interested in a process of getting new information, updating and improving the document in any way that we can.
Okay, Mariam Shernuda, why don't you come in here at this point and tell us what your original concerns were with the original crisis triage protocols that came out 10 months ago?
Yeah, so there were several. Procedural and substantive. So procedurally, there was a lack of transparency. I of course hear what James is saying about it was a very rough time. We saw what was happening around the world. We wanted to make sure that doctors here didn't have to be put in the position that doctors in Wuhan and Italy and other parts of the world were experiencing. Another issue, though, was lack of consultation. And we are now in January 2021. We're in the midst of wave 2. We've had, or the government has had 10 months to be more transparent, to hold these consultations. And, to James's point that it was supposed to be replaced, we don't know what it's been replaced with. The Ontario Human Rights Commission has written to the government and told them, please provide us with what has been distributed to the hospitals as of December. And we haven't gotten that opportunity to review that protocol. So we don't know what it's been replaced with. And there's still been a lack of consultation. There's still a lack of transparency. Substantively, and Steve, I don't know if I'm jumping ahead, but the tools that were implemented or advised to be used as a guide by doctors, like the clinical frailty scale, were of deep, deep concern to persons with disabilities.
Well, let me jump in there if I can, because that'll take me nicely to David Lepofsky. The clinical frailty scale that was just referenced. David, perhaps you could tell us what it is and what your concern with it was.
Okay, and I think I want to answer that with the question you asked, Dr. Downer, but with a much more direct answer. The protocol which Dr. Downer co-wrote and which was in place from March until the end of October was inherently and unjustifiably discriminatory against patients with disabilities. And eventually, after we finally got a chance over the summer to prove that and show that and demonstrate it to the government's advisory bioethics table, of which Dr. Downer is a member, even the bioethics table agreed that what they had earlier recommended was actually discriminatory unfairly against people with disabilities.
But have they fixed that now?
And well, only in part. They haven't. They took it away at one part, but they've actually left it in place in another part. So what is the clinical frailty scale? What that earlier protocol had included, and what the only thing we've seen lately still leaves dangling out there as a tool that can be used, among others, is basically says to decide which critical care patients needing life-saving critical care will be triaged in or out, will be allowed in or rationed out. This will depend on whether they have a progressive disease, and if so, whether they are incapable of doing some or all of 11 activities of daily living without assistance, like getting out of bed, or shopping, or doing their finances. And so for patients with disabilities, that means people with disabilities, take away your assistance and see if you can do it yourself. Well, that's a fundamental violation of basic human rights principles, much less is it a fair assessment of whether they are likely to live or die if treated. And so we pointed out that what the bioethics table and Dr. Downer had recommended last spring, and which the government left in place over months, was in fact discriminatory and pressured and pressured. Finally, the bioethics table agreed, and eventually the Ford government rescinded it. They should have done that 6 months ago.
Okay, let's get Udo Schucklink in here at this point, because we've got medical people, we've got advocates for disabled people here. We need a good bioethicist, and that's you. Tell us the tightrope that all groups are walking in a case like this, because we're dealing with some of the most, this isn't the right word, but you know what I mean, some of the most treacherous ethical considerations of life and death that are imaginable here. What's the mission?
Well, yeah, so you're right. You got to ask yourself as a government or as people writing guidelines, what it is that you're aiming for? Because you find yourself in a situation that, our title today is Ontario's Crisis Triage Discriminatory. And the long and short of that is, of course it is, and it has to be discriminatory. It has to discriminate, for instance, say they have to make choices, for instance, they have to decide whether they make sure that somebody survives based on their life expectancy or on their quality of life, because they are not able to treat everybody. So for that reason, any triage protocol is discriminatory, because by virtue of the decisions that they make, they will always discriminate against somebody who then will die as a result of that decision. And the only reason why that is necessary is because they know at the outset that not everybody who needs care will be able to get that care. The question then is whether the decision that is being made, that is, in other words, the discriminatory decision that is being made, whether this discrimination is justifiable or not. And this is what David alluded to earlier. And he, of course, thought that the old protocol that I haven't seen, quite frankly, because it was so secretive, that this discriminated unfairly against disabled people.
Do you like the new protocols better?
I think the new protocol actually is pretty good, because, I wouldn't have written it that way, but I also don't think it's a terrible protocol, because here what they're doing essentially is they still try to preserve the maximum number of lives that they can preserve. And they have a sort of a rider on that. They're saying you need to ensure at least that somebody does not just survive, but survives at least for 12 months after the intervention. In health economics, for instance, when they talk about resource allocation decision-making and the ethics of that, they often aim for other things. They aim, for instance, for maximizing the number of life years that you can preserve, as opposed to just lives. So it wouldn't matter then whether somebody is 50 or 94, for instance, just to give you one example. Then the younger person would be, there would be discrimination in favor of that person.
James Downer, you've heard some of the criticisms and some of the support of your efforts so far. I should give you a chance just to comment on what you've heard so far.
Yeah, and again, I don't want anything I'm saying here to be taken as a personal criticism of anybody on the show or anybody else for that matter. I do think it's important, though, to just correct a few points in terms of procedure. We have been engaged in extensive consultation with many groups, including disability groups, including clinical groups, including groups representing Indigenous populations, many others. The list goes on. Literally hundreds of people over a matter of months to get input to go into this document. And the consultation certainly is by no means over. I think everyone's committed to an ongoing process of trying to refine and revise this in a positive way. So just to be very clear about that. The other thing that's important to say is that the bioethics table, I think at no point really said that they felt that the protocol or the document that we produced was unjustifiably discriminatory. What we are trying to do is that we have a number of principles and that we're trying to sort of balance here, right? That broadly speaking, it's the desire to save as many lives as possible, but also to be very procedurally fair and try to make sure that we're not, disproportionately affecting one population or another. And as you're trying to sort of defend human rights, but also protect human lives, trying to find the way to best balance that is hard. There's no one right answer.
Okay, can I ask you about one of them?
If I can, sure, go ahead.
Okay, because we just heard from Udo saying that the notion that you should be able to survive for at least 12 months after care is a consideration in how doctors will do their work. And I guess I just need to know, what's magic about 12 months? How'd you land on that?
So the challenge here, right, is that you're trying to, I mean, when you're talking about saving lives, what do you mean? Like, there's many ways to capture the concept of saving lives. Are you trying to have the most people survive just to the point that you can get them off of life support? Well, nobody really thinks that that's the purpose of healthcare or critical care, is just to survive literally to the point that you make it to the ICU door. You're hoping to survive for at least some sort of period of time and make a recovery. But if you start to get out to 5 and 10 and 20 years, then it becomes implicitly ageist, right? That there are certain people who may, just because they're in an advanced age, would not have that many years to live. But it's not really about their mortality risk per se. So you're trying to find the balance between a protocol that talks about survival and recovery, and not get too far into ageism. It's not strictly speaking about who's going to live, how long any individual might survive. It's about mortality risk. So the purpose of these tools, and I'd like 2 minutes to talk about the tools if I can. The idea is that we're trying to create tiers of risk so that, and ideally, if we have enough resources, everybody gets the resources, right? Nobody is excluded from critical care under the protocol. The idea is that as the surge in demand climbs, and we get to the point where we literally just do not have enough to go around, that we're sort of trying to focus our resources on the people who are most likely to benefit, people who are most likely to survive if they get critical care, but not survive if they don't. So that would be the benefit in that sense. But the idea that, is it 12 months? Is it 6 months? Is it 18 months? The idea is that the people who would be in those 4 risk groups, if you're looking at a 12-month risk of mortality, would be the same people in those 4 risk groups if you looked at 6 months or 18 months. The focus on the duration of time where you're looking at the data is not really a substantive concern, because whether you looked at their mortality at 6 months or 12 months, it would end up being the same individuals. We're just trying to say that, we have data, and a lot of the mortality prediction tools and clinical guidance that we're giving people is focused on data of mortality out to a year, because that in the public's literature is what we have.
Okay, I get you.
I'm going to come back to the clinical.
You know what? You got to forgive me, James Downer. I gotta try to keep the time as equal here as possible. So let me get to Mariam on this next question. This is a real hard question, but this is all life and death stuff we're dealing with here today. Under what circumstances, in your view, should someone be pulled off a ventilator in order to give it to someone else? Because that's the scenario that many doctors and nurses are going to be looking at potentially if we don't flatten the curve.
Yeah. So, Steve, I have a real problem with examples like that, because what we're talking about, and this goes back to what Professor Checklank said and a little bit about what Dr. Downer said about this balance between ethical principles and the human rights framework. And they've been equated from the very beginning within this triage protocol. And that's problematic for several reasons. The first one is ethical principles are just that. They're principles. The human rights framework that we have are quasi-constitutional rights that are bestowed upon all of us. So you shouldn't be drafting a triage protocol to answer questions like the one you just posed by looking at ethical principles. You should be looking at a human rights framework. Second, the ethical principles that do guide this document are, some of them in and themselves, discriminatory. By way of examples, utilitarianism, which was mentioned at the top of the program and has also been mentioned by both Dr. Downer and Professor Checklank. Utilitarianism talks about the maximum benefit of good for the maximum number of people. The problem is that when we look at this, persons with disabilities hardly ever comprise that maximum group of people that have received that benefit. So the ends justifies the means, which pretty much is utilitarianism, will always be discriminatory to persons with disabilities.
But if you don't use that philosophy, what should you use?
The human rights framework. And the human rights framework talks about A, the duty to accommodate, and B, up to the point of undue hardship. It's not this idealistic idea of fairness. It's substantive fairness as set out in Section 15 of the Charter. So to dilute or to equate ethical principles with human rights framework is to dilute a very robust system. And just one more point on that, Steve, to say that we just don't have time, we're in a pandemic, we need to be efficient. This is the type of scenario where human rights matter the most. Human rights aren't triggered when things are easy and people are living a happy life. Human rights are especially triggered in these most dire of times. And we can't trample over them for the sake of efficiency and by trampling them by putting in ethical principles as taking primacy over human rights. I don't think that's appropriate.
Okay, Udo Schukling, can I get your view on whether we should take a more human rights-based lens as we look at this issue versus a more philosophically utilitarian lens on this? What's your view?
Well, I'm biased here. I am a utilitarian, so I do care about outcomes. And that's the nature of healthcare systems. Healthcare systems always try to maximize human well-being. I have issues with the human rights argument, because the truth is none of these charter rights are absolute. They can all be overridden, provided we have a good justification for that. So what the previous speaker has just done, basically, she has hidden behind human rights rhetoric, but she dodged your question. And the question remains. If you have somebody who is in a hospital setting, and I worked many years ago in South Africa, so I've actually seen this as a clinical ethics person, like I was on the bedside. And you find yourself in a situation that there's a patient there that is on a ventilator, has not a really good outlook in terms of survival, and there's somebody else who needs access to that ventilator. And you know that this person with a much higher probability will be able to leave that hospital. Are you then going to, as the previous speaker has just done, no, we can't do this and we must not do this, and outcomes apparently don't matter, it's all about rights. Are you really then saying, okay, we stand by, we wait for this person who could have left the hospital to die, and the other person is also really going to die, but we certainly will not wean that person off the ventilator. Suffice it to say, in South Africa, of course they have weaned that person off the ventilator in order to save this other life.
David Lepofsky, you want to weigh in?
Dr. Danner, and more significantly, Professor Schukling, may give you ideas from the point of view of bioethics. I'm sorry, but we live in a country that's governed by law and the rule of law. And some of what Dr. Schukling just took as utterly acceptable would, I think, need to be explained. Someone need to explain to me why it is not culpable homicide under our criminal code. And you can't, even underlying all of this discussion has been even this implicit premise that somehow the government can send a memo to hospitals deciding who lives and who dies without any proper legal authority. Now, the bioethics table in its most recent writing has suggested a greater recognition that we need to have a legal support. But I'm telling you categorically, any doctor who does what Professor Schukling just said without legal authority better be consulting a lawyer, and fast. This is not a question of philosophy first. The law prevails. Second, Dr. Schukling's understanding of the way the Charter of Rights and Human Rights works, I'd respectfully suggest is fundamentally and severely flawed. And I know this stuff, I teach it, I've practiced it for decades. And let me just address a couple of other points. Dr. Danner said, oh, there's been lots of consultation. Yes, last summer, we had discussions with the bioethics table. It's an external advisory body that advises the government. We have not been able to have one word of conversation with anybody in the Ministry of Health who's actually making the decisions. They have refused to talk to us. The Minister of Health has refused to answer any of our 6 letters with our most basic inquiries. The image you got from Dr. Danner of, oh, this is also consultative. Yeah, the external human shields, the bioethics table are out there talking to us, but the people making the actual decisions aren't. And why that's significant, Steve, is because the one time we heard 2 minutes from somebody who's actually a member of the government's internal body called their Critical Care Command Center, a Dr. Andrew Baker, on a conference call that we had to give our input a couple of weeks ago, he took a position or an approach which is at odds with the bioethics table's recommendations, and I fundamentally believe at odds with our human rights code and our Charter of Rights. I'm happy to go into it if we have time.
Well, no, David, forgive me. I wish we did. Unfortunately, we don't, and I really need to let Udo respond to the comments you just made. So go ahead, Udo.
No, actually, I wanted to just say that we have common ground with regard to the status of this document, because I'm just like you, completely puzzled about it. When you look at the charter that this bioethics table itself has, it's very clear that these documents themselves are meaningless until government adopts it, whether they do it in form of legislation or by some other means, and then you can sue over this. I understand all of that. But right now, at least, that document has no standing until it is adopted by government. It's just the opinion of this table. And the table itself makes very clear that this is how it understands itself. It basically provides government with these sorts of guidance document, and government then has to decide what to do with that. But prior to that, that document has no standing, and it shouldn't, of course.
And even under it, each doctor, we take issue with the 12-month timeline. We think it's too long. We take issue with the lack of due process. The document recommends more than there was before, but patients deserve an independent legal safeguard when their very right to life is at risk. And we take issue with the fact that, in effect, under the document that we are now talking about, which is the one the government circulated after repeated pressure and questions in the legislature, not before, each doctor assessing each patient would ultimately be a law unto themselves, applying no clear standards with rampant room for subjectivity and therefore serious risk of bias, including discrimination against people with disabilities that they may not even be aware they're doing.
David, let me jump in here because we're down to our last few minutes, unfortunately, and because you are visually impaired, you could not see Dr. Downer shaking his head in the midst of that answer. Dr. Downer, you want to push back on that?
On a few points. Right off the bat, I just think it's really important to note that the purpose of these clinical tools are that they would be applied to specific medical conditions for which they are relevant for predicting mortality. There's only one eligibility and prioritization. There's only one prioritization criteria we use, and that's mortality risk. So references to things like the clinical frailty scale are meant to apply only to people who have frailty, not to all individuals with disabilities, chronic disabilities, people who are younger than 50. These are people for whom the clinical frailty scale is not prognostic. And that's been very clear, I think, from a very early stage here. And we've tried to communicate that. You don't apply clinical frailty scales outside the people who have frailty, the same way you wouldn't use our cancer tools to prognosticate for somebody who doesn't have cancer, the same way you wouldn't use heart failure tools to prognosticate for people who have heart failure. I think it's also extremely important to note that, even in this sort of this notion of human rights imbue everything we do. We are human rights focused people. That is what we're about. All of us are trying to make a better system here. But the idea that we're sort of sacrificing human rights, I just don't think is correct. The purpose of having clear, explicit criteria is that they are the antidote to implicit biases. They are the antidote to subjective judgments, is to put clear clinical tools out there that enables people to have a standard against, just let me finish, David. I didn't interrupt you.
Sure.
That there are clear standards that people can apply consistently, that they're standardizing mortality risk so that somebody with heart failure can be compared to somebody with cancer, can be compared to somebody who comes in following a car accident. And we're trying to treat everybody as fairly as possible. And again, we don't want to restrict access to anybody. We would love it if we could simply offer critical care to every single person. The notion, though, that there's this sort of pushing aside of human rights, some of Canada's foremost rights lawyers, that Jocelyn Downey wrote an editorial saying that our Ontario protocol should be adopted nationwide. Our protocol has been served as the inspiration for similar protocols that were accepted with enthusiastic support of disability groups in Quebec. It's been adopted in Israel.
I gotcha. I'm down to a minute and a half, though, and I want to give David Lepofsky a chance to respond.
Dr. Downer conceded in conversations with us at his bioethics table consultation that the clinical frailty scale, which he is the passionate defender of, includes subjective calls by doctors.
Don't they do that every day anyway, David?
Well, not when you're doing objective assessments. The point is, don't tell us that it is an objective requirement when it is a subjective one. Each doctor will be a law unto themselves. And not only that, but when I asked Dr. Downer last summer during these consultations about how doctors make palliative care assessments, whether you've got 3 months to live to qualify. Now that's the situation of deciding if you get into palliative care, not whether you get critical care. But Dr. Downer said that doctors lie. Now, he's not meaning lie, and I don't believe in a nasty sense. He's saying that essentially, if I understand correctly, they will say what they need to say to get the person in. But that's the same kind of subjective risk we're facing here when you change 3 months to 12 months. So
okay, I got to give him 30 seconds to respond to that.
Absolutely.
Dr. Downer, finish it off.
What I said was that when there's scope for and the ability to use judgment, that physicians sometimes will give prognoses that are shorter for the purpose of getting them more resources in a home care setting. This is physicians using their discretion to get more resources for their patients because they're advocating for their patients. That was what I said very clearly to you, Mr. Lepofsky. They're not lying to suit their own needs or for their own convenience. And that's a very, very important distinction, Mr. Lepofsky.
Okay, friends, forgive me, I got to jump in. We need you four back for another program because as much as we had a good half hour on this, we need more time. I'm grateful to James Downer, Udo Schucklink, David Lepofsky, Mariam Shenouda for joining us on TVO tonight. Thank you all very much.
Thank you, Steve.
Thanks so much.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.